phone. I'm going to go through the names of the individuals who I've seen join us thus far. If I miss your name, if you could at the end, please just announce yourself for me. I see Bob Atlas has joined, Will Daniel, we have Dr. Haft, we have Kevin Hayes, Debbie Kuchka-Craig, Gene Ransom, Dr. Riebman, our executive director, Ben Steffen, and I don't know if I've missed others. So is there any council member that you did not hear me announce your name? If you could indicate your presence, that would be great.
Hi, it's Patrick Dooley.
Good afternoon, Patrick. Anyone else?
Yeah, Bob Berenson's here.
Dr. Berenson, good afternoon.
Good afternoon.
I see Tricia Roddy is joining. Good afternoon, Tricia.
Good afternoon, everyone.
And again, just back to the council, any names that I missed that did not have a chance to announce?
Hey, David, I don't know if sorry, I was distracted. Bob Atlas here.
Yeah, no worries. Good afternoon, Bob. Okay, so why don't we go ahead and get started? As usual, we talk a little bit about some of the logistics. So I'll invite Melanie to talk a little bit about how the meeting will play out in terms of the meeting logistics. Melanie.
Okay, thank you, David. Can everyone hear me okay?
Yes.
So as usual, the meeting is being recorded. Please contact Annette or myself, or you can send us a chat message if you're having any technical issues. You can mute and unmute yourself using the small button at the bottom of your screen that looks like a microphone. Staff may mute you if there is background noise that looks like it's coming from you, but you can always unmute yourself if you'd like to speak. The chat function does send messages to all attendees. This technology does not allow you to send a message to a specific attendee. Since there will be a lot of people in the meeting, we ask to sequence speakers when possible. We understand there's times when people just want to speak and you don't have to wait for a turn, but we do ask that if possible you do. What we typically do, take a piece of paper, fold it and hold it up. You're welcome to hold up anything else that we can see, but that's one way to signal us that you'd like to speak. You can also send a chat that you'd like to speak, and someone can read it on your behalf. So those are the different ways we can do that. So at this time, I'll turn it back over to David to lead the meeting.
Okay, thank you. And late joining, welcome is I saw Robin Elliott and Dr. Okiki. So thank you for joining. Before we get too deep into the discussion tonight, we wanted to start off by inviting Dr. Haft to say a few words. There's a couple of items that we have on the agenda that he's planning to talk about. So with that, Dr. Haft.
Thank you, David, and thank you, advisory council members. And just a couple quick things. One went out to you already in the email, and I just wanted to just review the fact that we're now planning on finalizing the quality measures 21, and you have some suggested quality measures in your email that I'd like you to reflect on, and if you have some opinions about those, provide them back to us so that we can finalize that hopefully this week. And the measures that we'll have going forward will be continue the measure for diabetes control and hypertension control, but contemplating a measure for unhealthy alcohol use, screening and brief counseling. This is kind of an expert measure. And I'll point out that that's one that does not yet have a QRDA3 for it. So it would be, as current state, it would be one that would have to be manually uploaded into the reporting system. But we anticipate in the future that it may be converted into an ECQM and be able to be uploaded more easily. It specifically is for alcohol use and follow-up. The second that CMMI has suggested, if that is not effective, if that is not accepted, that we, in order to reflect on something close to substance use, they suggested depression and the depression screening and follow-up measure, which is one that's well worn. Many or most practices are used to reporting on that. It's been around for a long time. The next is consideration of NQF 0421, which is the BMI screening and follow-up. And that links us a little further to the state's overall goal of reducing diabetes incidence by being able to identify individuals who have an elevated BMI and putting them into a weight or management program of some kind or another. So just want you to reflect on those, and then we'll accept your reflections and get back with CMMI as we work to finalize that for 2021. So just stop there on that. And this is not for discussion, just to let you know that we appreciate your comments. Next, I wanted to say that CMMI did respond promptly to the letter that we wrote together with the secretary to them, requesting some additional time to deliberate on a track 3, and they effectively extended that to the end of the calendar year. They said that they would like by the end of the calendar year to have something that substantially looked like a plan that they could move forward through their clearance process. They did say that because of that time delay, the 2022 start was effectively off the table, and we'd be looking at a 2023 start. They've made a couple of other comments that are worth passing on, and then we'll go in more detail as the evening proceeds. One of them is that we should make every effort to have a program with downside risk that aligns with the total cost of care model that we're under. That the near final proposal should be available by the end of the calendar year, and that they would be happy to iterate with us on, but they would want to get 2 weeks to reflect on whatever submissions we gave to them in terms of progression on the plan. So we'll tonight put something together. It'll take a day or two for the advisory council and us to staff and us to put that into a succinct version. We'll send it to CMMI. They'll have 2 weeks to respond, and they'll give us 2 weeks if we need those 2 weeks to go to the next iteration. Hopefully we can do it quicker on our end than 2 weeks. And then we'll repeat that sequence till we get to the end of the year. So this will probably require some, as we move quickly down this path, some modeling, and we'll be looking for some additional technical help in terms of developing some models such as are required or requested by the advisory council and by the PMO to shed more light on the specific areas of interest. So that's all I really had to say tonight. I think it was very positive that we got a very good response from CMMI with complete understanding that it does take some time to develop these models. We have now to the end of the year, which is some time. It is still, I want to remind you, a very short time to do a lot of work. So appreciate what you've done already, and anticipate that there'll be much more work and thought that goes in it ahead. So now I'll turn it back over to David.
Thank you, Dr. Haft. Lana, why don't you bring up the requirements document? And while we're doing that, Dr. Riedman, there's been a few council members that joined. If you'll just indulge me for a moment, just to highlight the group again, that would be great. And I'll just read the last name so everyone's clear on who's on. So we have council member Atlas, Berenson, Chapman, Daniel, Dooley, Elliott, Haft, Hayes, Kuchka Craig, Okiki, Ransom, Riedman, and Roddy, as well as Wiedner. So that's the full continuum of advisory council members. Dr. Riedman, before you get started, if you'll allow me a moment just to acclimate the group to what they're visually seeing. And Alana, if I could get you to expand the size just slightly, that would be great. We heard Dr. Haft mention that CMMI has responded with comment, and what you'll see here in column 5, it says unresolved items for further deliberation. With the help of Dr. Riedman and Dr. Haft and Chad Perman, we have gone through and updated this column with the comments that were in the letter that you received, that was forwarded to you, I believe it was Friday, from CMMI with their comments. So you'll see that here, And the way we were going to approach it tonight is Dr. Reedman will frame up the requirements category, the design elements, and the components. And then we were going to ask, we're asking Dr. Haft if he would guide us through with a better understanding of the unresolved items. And then we're looking for the council to give us much more definitive, and for the moment, we'll call it actionable items for us to include in column 6, which would be comments. In past meetings, we've taken comments as they were stated and recorded them and tried to interpret them after the meeting. But we're hoping tonight we can actually focus in on answers to the questions that CMMI has asked. And while these are statements, essentially this is the information we should get back. So with that, I'm happy to answer questions. And I see Bob Atlas has one. So welcome, Bob.
Thanks, David. It's really a question of process. So the feedback from CMMI came like late last week. And, I can't, there's a lot there. They basically, on so many things, they just asked for more information. For the MHA does not have, complete knowledge to be able to represent all hospital interests and just coming up with the answers. So we need a little more time to, and we are convening folks who represent the hospitals to discuss this. So, thinking about that proposed back and forth of every 2 weeks back and forth, I think maybe we shouldn't rush to try to get a complete set of answers in the next week or so. Let's take a little time to give our best shot on the first response, and then get into the back and forth. And that way we can be sure we're not debating things that we actually would rather not later on. And I'll also just add, while I have the floor, that it's worth talking about each of the details individually, but for us, because of how this is connected to the big Maryland model and CMMI's impression of how Maryland performs on the grand bargain, so to speak, we have to look at it also strategically rather than, line by line tactically, in terms of, the receptivity of CMMI to Maryland's overall, if you will, attitude to this. So there's a lot here. I hope we can kind of not expect to, have all the answers figured out this evening. It's just, it's too soon and too much.
That's a very good point. I would invite Dr. Haft to add some commentary based upon Bob's remarks.
No, I think, Bob, that there's a great wisdom in what you're saying. We don't want to try and be too fine in the response now, or too quick in the response without you're thinking about strategically how we can move it forward within the time frame that's given. So I think it makes good sense what you're saying. I think we need to temper it by the fact that we are in the middle of September, and if the deadline was moved, it was moved till the end of the year. But if we have a 4-week cycle for iteration, if it's 2 weeks and 2 weeks on either side, it gives us this cycle and then perhaps 2 more. So it would also crunch things up at the end.
Yeah, I'm just saying, don't expect to get a complete enough set of inputs tonight to be able to start that process to deliver the next salvo based on what we come out with tonight.
So, Bob, my expectation would be that, and the hope would be that we go through this sequentially, get through what we can tonight that we're comfortable with, and that as we submit, and I think we're going to have, and our plan is to try to kind of have every Tuesday meeting till the end of the year, and there may be some we skip because we don't need them. But I think Howard's point is well taken, that we don't want to get too far ahead of CMMI, but we also can't wait for their responses each time. So I think we get through what we can, we submit it to them. and then we keep moving forward and submit again, and then they may be a meeting behind us with their recommendation, but at least we keep moving forward with what we want to get through and submit it when we're comfortable submitting it. So I think your point's well taken.
So with that, Dr. Reedman, why don't I turn the floor over to you to start?
Okay. So actually, I was going to start off with exactly what Bob had asked, and that, kind of an update on where I think we are at the meetings and the fact that we need to keep moving aggressively, despite the fact that we're looking at delays getting back from CMMI. I do appreciate everybody's input up to this point. We've kind of touched on general theories. We've discussed this all at length, but I think our goal from here on out is to really get down to the specifics. As Howard mentioned, we're looking at potentially modeling out some of these numbers, in particular some of the financial impact and what the base rate should be. So we'll get into that a little bit more tonight. I'll let Howard talk a little bit about it. But the first item on our agenda, as you can see, is our total monthly payment. The practices are paid to deliver advanced primary care. I'm not going to read through all of this, but because we've done this before. But the big things I think there are the fact that how the population-based payment practice is divided into 4 groups based on the average hierarchical condition category, the HCC risk scores. There's that flat rate of $40.82, which we will discuss further, and we've had conversations about whether that is a reasonable number or not. And that the TPCP will include some adjustments to accounts for variations in cost to care and encourage practices to actually manage their attributed patients. And then we kind of agreed to population-based payments and agreed to the flat fee payment rate if it's a reasonable number. And then the column that we'll have Howard chime in on is the one that's more significant for tonight. And that's really what we felt were unresolved items for further deliberation. And if anybody on the committee feels like we haven't covered any of them, we need to cover others, we'll go to that point. But I'm going to let Howard go ahead and take it from those 3 items for this discussion, and we'll move forward from there.
Dr. Happ.
Yeah, I think so. The first item here is the HCC scores at practice level or at the individual level. I think this is one that, it needs to be modeled out. I don't think that we can make a reasonable judgment without seeing how the shift from the way that our practices are paid now, which is essentially the money follows the person, so that depending on where an individual ranks in their HCC score compared to the total HCC scores in the program defines their tier for payment. And so practices that have a mixture of patients, some complex and some not so complex, will get paid according to those patients' complexity. The way that the design is in primary care first, a practice, the average HCC score for the practice overall is developed, and then they're cast into one of 4 groups. The lowest group getting a much smaller average population-based payment, or getting a smaller population-based payment for all beneficiaries, and then moving up the scale through the 4 groups. So our back of the envelope modeling, which is not to be used for making judgments, indicates that our practices, the majority of them would be in groups, the vast majority in groups 1 and 2, the largest in group 2, slightly less in group 1. And in group 1, the payments would be significantly less, very significantly less than what those current practices get. In group 2, it would be less, but not so significantly. And then in group 3 and group 4, it would be more. But we'd like to provide some more very specific modeled out information for the committee to see the what ifs and make some judgments on that. So that I think will require modeling.
So, Dr. Haft, is it reasonable at this stage to just get a finger to the wind on what the thinking is from the advisory council on absent data, if there's a policy process that would be more of a preference? Dr. Reedman, your thoughts?
Yeah, I'd like to add some of that and I'm not sure how this honestly fits into a recommendation from our committee, but I would like in particular some feedback or some comments from the other practicing physicians on the committee that, the HCC scores we're heavily weighted on those. Our reimbursement is heavily weighted, and I understand all the complexities of the HCC scores, but it is not an easy process for clinicians in the office seeing a patient to pick the appropriate HCC scores. They can be complex and they can make a dramatic difference on whether someone's diabetes is causing their renal failure versus not. And those scores are critical for, not necessarily for practicing medicine, but they are critical when you look at reimbursement and for population health and tracking. But I'd like to comment on how difficult the other providers find it to pick the right HCC scores. Especially when you're seeing complex patients and you're already running behind, and how do you do that? And I mentioned before that our group is using Epic, which makes this a lot easier process than our older one. But I do worry about the heavy weight placed on the HCC scores and how that affects the practice.
So thank you. Dr. Wiedner, from Dr. Riedman's point, and you may be muted.
I was thinking about this, and certainly with REMR, we can see whether a diagnosis has an HCC score applied to it or not. But what's that score for each individual diagnosis? I can't tell, but at least it helps me pick that out. So if that answers your question, Dr. Riedman, in a way that helps with Allscripts Pro that we have, as long as there's a high level of transparency of what would determine a practice level HCC score, I mean, that would be something that I think we need to have made in this, that if they're going to determine just one score for the practice, I mean, what I appreciate now is I can see which individuals, according to have which HCC scores applied, and hopefully that'll still be the case and build that pre-AH tool in CRISP and allow us to stratify risk for patients to identify them. But this is more, I think, talking about just the payment issue and how is it going to be paid. So I think the modeling will help us understand that better, Howard.
Thank you. Dr. Okiki? And I think you're muted.
Yes, I was. Can you hear me now?
Yep.
Yeah. So I agree with what they're saying, and I will look at this from a population health perspective. The HCC scores, the way it's currently used, is really for payment, but there's also that clinical judgment that's applied by the primary care provider as well that populates the clinical risk score. Some folks use that in combination, and some folks use AAFP or other tools. And really, when that clinical risk score, there's a discrepancy between that and the HCC score, I think that's an issue, because going forward, that's how the provider and the care team, identifies who's more higher risk and start, applying the necessary interventions. So back to Dr. Howard's point, he said, I think this will need some more modeling. I hope that the design of the modeling will take into consideration a look back period of the different risk tiers and see over time what was the discrepancy over time between the HCC score that came from CMS versus what ended up being the clinical risk score assigned by the physician, and see what that delta is, and sort of, have some predictive value that's adjusted for going forward. That would be my suggestion.
Okay, thank you. And Dr. Berenson, and then Kathy Chapman, please. Dr. Berenson?
No, I don't have any comments on this.
Okay, thank you. Kathy?
I agree with Dr. Kiki's comments. The HCC score as we get it now currently through Medicare is not all that helpful. I'll give an example. I had a fellow who was end-stage cancer, and his HCC was very, very low. And that was because he was still working when he was going through all his evaluation and treatment. And then when it progressed to the terminal status, then he was no longer able to work. So he left his private insurance, which had paid all the bills, and then went to Medicare. So his cost of care was really low according to Medicare. So that was very misleading. The two-step verification or stratification of risk is really what we use more to guide our care. The other concern I have is that we are dependent upon CMS to get us accurate information of our patient load. I recently printed out our beneficiary list, and on the first page alone, there were 21 patients that were attributed to our practice that should not have been. They'd gone to the nursing home, they had passed away, they had transferred care. We are unique in that we are a blended practice. We do mental health and physical health, and my mental health patients were attributed to me for primary care, even though someone else did primary care. The flip side happened. I have a fellow who goes out west every year. He was injured, ended up going to the ER and had to have primary care follow-up. He was immediately taken off my list. Even though people I haven't seen for 3 years are still on the list, he was taken off. Now that he's back in Maryland, I've got to get him back on the list. Is that going to happen quickly? Is that going to be 3 years before they correct that? So the accuracy of information from CMS of our patient list is very concerning to me, and the impact that's going to have on a practice financially.
Understood. Thank you. So could I invite Patrick Dooley if you're able to make a comment? And if not, perhaps Jean, you have some general thoughts that you might want to weigh in on?
Sure, this is Patrick. So I think, I'll agree with the clinicians on the line about we need to make sure the data is accurate and everything else. I think, to me, I'd kind of like to better understand why CMS does it at the panel basis versus at the individual level. I mean, there are all sorts of examples in CMS programs about, patient-centered care, money follows the person in Medicaid programs and other things like that. And so, I assume there's a method of the madness of why we would do it at a panel rather than at an individual level basis. But, if the basic premise is to align the dollars with the care that's needed for specific individuals and not to just create kind of average blended payments across the board, which might not actually reflect what that individual needs. I think, at least for me, I'm not aware of why CMS is kind of doing it one way versus another, and particularly since the primary care program is already done at an individualized basis, I'm not sure the lift that it would take to continue that sort of workflow, when I would argue that it probably makes more sense from a policy perspective to continue to do it at an individualized level.
Understood. Jean, then Dr. Berenson.
Yeah, I just strongly support what the physicians said earlier on the call. I don't have anything to add from their comments at all.
Okay, thank you, Jean. Dr. Berenson.
Yeah, I don't have any specific knowledge of why CMS is moving to the practice level, but I would hypothesize that you get much more confidence with small numbers by merging the data for various physicians in a practice rather than at the individual level, where a few patients can seriously affect the HCC score. You'll have much larger confidence in what you come up with if you have a larger N. I'm guessing that's one of the primary reasons.
Very good. Will, are you able to give us a perspective from your experience, former experience, and then Ben?
Will, on the payments of the HCC versus the practice panel?
Yeah, HCC score globally versus individually.
Unfortunately not. I don't have any particular insight on it.
Okay, thank you, Will. Ben, your thoughts? And Ben's muted.
In the RFI, there is a discussion of why they have gone in this direction, which is CMS states that they want practices to focus on the patient population overall, as opposed to the specific patients, which doesn't exactly make sense to me. But it may actually be, the debate may not be necessarily on average versus individual, but the levels and the gradations between risk groups that's most important. That how are those differences calculated, and are the gaps between them really can they be justified? Clearly, I think we got to go back and look at some of our Maryland data to understand that. But I think inherently If it's designed properly, you should be indifferent as to whether it's individual based or group based, as long as those group payment levels are precisely capture the overall average risk for that patient population.
So thank you, Ben. Dr. Berkowitz joined, and your thoughts on risk score at the practice or individual level versus the individual level?
I don't have anything to add to what's been said at this stage. Thank you.
Okay. So Dr. Haft, is it at this point, if we leave this as an open item, do you suspect CMMI is going to be looking for some directional guidance in the next version that they get, or are we okay by signaling that this is still this is an item under consideration and may take a while depending upon how long modeling would take to complete?
Yeah, no, I think that's what we indicated in the letter, that this required some modeling, and they acknowledged it would require modeling, and that we would respond after that. And I just want to also point out, I think that one of the purposes of the model is to see whether this method, shifting from our current method to this method, either significantly advantages or disadvantages both the program as a whole or significant groups of practices. And knowing that there's interest on both sides, certainly if shifting to this method caused a sudden large increase in overall total costs, it would have an effect, as I think as Will and Bob Atlas have pointed out, to the model. And if it had a sudden significant effect on a decline in payments compared to current for practices, it would have a chilling effect on practices proceeding forward or joining the model. So either of those things would be notable. If it's middle of the road, seems to disadvantage and advantage equally, or a moderate effect, that would also be important information to know. And I think that will drive decision making probably more than the kind of the uncertainties about HCC scores and inaccurate data, things that we've lived with and will continue to try and combat for years, but may be more challenging to fix than just simply coming to a decision of how to model this going forward.
Dr. Riedman, your thoughts?
So Howard, I was going to ask, so if we're going to, I think putting their modeling will inform recommendations is a reasonable thing to submit to them now. Should we also add, though, some of our concerns now, or do you think it'd be best to wait till we do the modeling to add some of our concerns to these comments that we submit to them?
I think that would be better to package together as we've done the model. Here's our conclusions, and here's the reasons for those conclusions.
All right.
Dr. Haft, do you want to take us to the second bullet point?
That's Maryland model effects and complexity.
Yes.
So this is kind of a general. I'm not sure how it. Honestly, not sure how it floats over from the flat fee visit payment. So if I can just comment on the flat fee visit payment, I think that's also something that we simply need to model and find out what the intention for this flat fee payment was, and maybe this is the part to discuss, was again to provide a payment that reflects neither an incentive nor a disincentive for a face-to-face visit, knowing that the majority of the payments will come out of population-based payments, which free you up from the need to have a constant churn of face-to-face visits, and knowing that face-to-face visits still are important. What is the point of neutrality that neither incentivizes nor disincentivizes a face-to-face visit? That is one that reflects the basic cost without significant profit for a face-to-face visit. I think that's something we again can look at with some modeling and come to a number. Then, if that's what we would choose to do here, is if that is the principle that we want to follow. The principle would be, what is the basic cost to a practice to do a face-to-face visit, independent of whether it's complex or or simple, and what's the average median point or mode for that?
Dr. Oh, thank you, Dr. Happ. Sorry, I didn't mean to cut you off. Dr. Berenson, any thoughts?
I had to find my mute button. That was I articulated the same point of view. Dr. Haft has reflected it just the way I thought it should be. I guess the only two other things I would say is that another consideration in establishing a single fee level is that the billing cost as a percentage of the fee received shouldn't be too high, and $40 and whatever it was, it would be very high. And I think the data analysis Dr. Haft recommends would produce a higher number for that incentive neutral rate. And then it's worth billing it. At $40, it's barely worth billing it, frankly, and creates distortions. So I think that is a good model. I think it's also actually that principle of incentive neutrality goes to sort of trying to find the right blend between, well, this is them. Never mind. I was going to go somewhere else. I'm not going to do it. In any case, I agree with what Dr. Happ said.
Thank you.
I think that we've had this conversation. I don't want to prolong today's conversation on this subject because I think we do need to model this out to figure it out. It's certainly from the data that we've looked at and heard from others is that probably somewhere between a level 3 and level 4 visit, what the billing for that is where this number should probably be. The large majority of primary care Medicare visits are level 4. A fair amount of number 3, but there's very, very few level 2s, and this number doesn't allow us to, as Dr. Berenson pointed out, it's really doesn't even allow us to do the basic for billing. So I think that number, and we've discussed it before, should be somewhere in that much closer to that $70 range, which is kind of in the low end of the 3 to 4 range. But I think until we model it out, we can't really have a more informed conversation, but I'm certainly open to anybody else has comments today about it. And if they don't and they want to wait for the modeling, if y'all feel that's appropriate, I'm fine waiting for it also.
Ben might have something additional to add to this. Ben, any thoughts? Mute. Oh, you mute.
I mean, I think we've kind of chased around this issue enough. We know what we ought to do.
Okay, so we'll put here pending modeling payments anticipated, somewhere in the $70 range, just as a note into the column, the flag it. And that would be a separate bullet, Alana. Okay.
So since we have some brains here, I did want to raise the question. It's not clear in any of the material I've seen from CMS on how they came up with 40. Now, if the assumption is that that fee is only to capture practice and malpractice expense, it still doesn't address the issue that Bob raised. But that would be, kind of, you could come up with a $40 payment because you're assuming that the work component is somehow captured in the population-based payments. I don't know that is, but that seems to me to be the only way you could justify a $40 payment, that you're only capturing the expense of operating that practice. I know I've heard Dr. Riedman react to that before in a very statesman-like manner. So, and it did provoke the expected response from Dr. Berenson too.
Well, I was just going to say, I would say it's probably opposite. I think the practice expense is captured in the population-based payment, and what you're trying to capture is the value of physician's time, the work component of actually doing a visit. And so I think actually we're capturing the practice expense elsewhere.
Yeah, okay, fair enough, good point.
Dr. Berenson, you should be relieved. Your wife will be compensated.
Dr. Kiki.
Fair enough.
Am I on mute? So question, if the timeline to have this done is before the end of the year, let me pause and get a yes or no to that. Is this modeling going to occur between now and the end of the year?
So,
Yes, I think we absolutely need to do that. So we're going to make every effort to make that happen as quickly as possible.
Okay. So my thinking was, if that will be done by the end of the year, then whoever is identified or contracted to do it would probably now need the council, some or all members, to help frame key requirements and considerations, including exclusions that we've all kind of talked around to inform that. I guess that would happen when that happens.
yeah, so Dr. Kiki, I think you're saying that information back to the council on the modeling is what you would hope to occur. If that's correct, I mean, I would say that's been the thinking all along, is that whatever the modeling produces, it would be shared with the advisory council.
That is correct, but also for them to design the modeling, there's a lot of things that folks have mentioned here that I think whoever is going to own it needs to be aware of, so that they can populate, those answers to those questions or those assumptions at the time. Because it can be, modeling is kind of a very interesting process. It can take you very different places. So,
good point. Good point. I think that's well put and speaks for itself. Dr. Behringer?
Yeah, I just want to remind everybody that two other issues related to this is, one is that there is going to be a significant fee increase. So if we're looking at some composite of level 3 and 4, rather than doing sophisticated cost accounting to come up with this fee, I think we have to be working off of new numbers. And then there needs to be some kind of mechanism for an escalator for inflation going forward. We don't want to in 10 years be paying the same amount.
Yeah, thank you, Dr. Berenson. Good point. Any other comments from council members that didn't get a chance to voice a view here? Okay.
Yeah, I think this is one that we will certainly have more conversation about, but I think again, modeling for these first two is going to be critical for that. So I'll turn it back over to Howard.
Yeah, so moving on, the Maryland model effects and complexity. I'm not sure that, that's a pretty broad category. I think where we were going with this particular category was to say that that the primary care first method of adjusting the payments, the population-based payments, was a complex method for adjustment that included a number of steps and a gateway, quality gateway after additional steps. And I think you've all had an opportunity to read through their method for adjusting the payment. And here, I think being able to adapt it more closely to the, still adjusting the population payment, but adapt it more closely to the methodology that we currently use with, that we use for adjusting the performance bonus portion of the payments would be probably simpler and easier for practices to understand and to also to adjudicate. There's a kind of a quarterly adjudication that occurs in primary care first, and an adjustment in payments, which the group may feel that an annual adjustment may create more stability. There's arguments obviously on both sides that if you're going to be adjusted up, you want to get adjusted up more quickly. If you want to be adjusted down, you'd want that to be more delayed. But I think the main argument is about stability of how stable or unstable and how predictable payments should be. So I think that here we would be looking at a discussion about whether payments would be adjusted on a quarterly basis or an annual basis, and what the basis of those adjustments would be. Right now we adjust based on utilization, based on a synthetic measure for for the state as a synthetic benchmark comparator. Primary Care First uses first a national adjustment and then uses secondarily an adjustment based on how you compare to practices in your state. So there's a 2-level adjustment, and you might want to choose a 1-level adjustment rather than 2. So there's a bundle of things within there that I think that we will either drive toward the more simplified version we have, or accept the more complex versions that are in Primary Care First, while at the same time saying yes, there will be adjustments on the population-based payments.
Okay, thank you, Dr. Haff. Bob.
Yeah, thanks. I'm just trying to understand this bullet point, Maryland model effects and complexity. Is that a reference to the interplay between this and the hospital global budget model? And, for example, I mean, I wouldn't have thought it would come up on this on the payment for primary care providers. It could come up in some other places, like what they're incentivized for beyond primary care, like when we discuss, should they be incentivized to reduce hospital utilization when hospital utilization reductions don't automatically get savings. So as the self-described protector of the big model here, I'm just trying to understand. Anytime you reference the big model, my ears perk up and wondering what's going on here.
Dr. Haft, comment?
No, I think what Bob said is correct. I think we want to have this aligned with the Maryland model. It's part of the Maryland model, and I think so that part I'm not sure. Again, what the reference is in this line item, and I was just really speaking to the complexity issue.
Yeah, I think that's a very good point. The payments are calculated at different intervals, some quarterly, some annually. It depends upon which particular area that's being discussed. Dr. Berenson, any reaction here?
Nope. You're asking me to react on stuff, but I don't have a dog in this fight. So no, this is local Maryland stuff. So I'm good.
Understood. So Debbie Kuchka-Craig, any reaction? She may have us on mute or stepped away. Patrick, any thoughts here?
Nothing in addition to what's already been said on this.
Okay, Dr. Friedman.
No, I was going to say, why don't we move on then to the next item? So Howard, I'll let you keep going.
Okay. Yeah, certainly. So, and I think this is an important issue that hopefully we can resolve here. That whether the design for this is as budget neutrality relative to fee for service, which means that essentially that the population-based payments and the flat fees would be roughly equivalent to fee for service income for practices, or whether it would reflect when we land on a model for payment, whether it would reflect some in the current MDPCP program level of primary care investment, or whether it would reflect an increased level of primary care spending.
So I have obviously strong feelings about this one. The purpose of, and we've had these conversations before, but primary care is about 5% of the spend, and what's being placed on primary care is more and more emphasis on population health, more work at the primary care level, more complexity of our reporting, and all the issues that we're being held responsible for. So I think if it's budget neutral for the current fee-for-service program, I think that reality is that primary care physicians have been underpaid compared to other specialists for decades and decades, and that a program that's asking for requirement of primary care to make more of a commitment and have more responsibility should result in at least an increase in the payments to primary care physicians. And I think that most physicians feel pretty strongly about that. But again, I think the program should increase the primary care overall spend. And again, a lot of that can be a risk if there's savings, and we understand that. But those savings should be passed on in no small part, I think, to the primary care physicians if they're doing the extra work for it. So I'll open up the floor from there.
Dr. Weidner. Okay. Dr. Okiki?
Mike, I think the only thing I would add to that is I know that studies have shown that to have a primary care system that thrives in a community, we're looking at 11% on average. I think the question would be what are we okay with, or what do we consider that percentage to be for the state of Maryland under the context of the total cost of care? And until we have key stakeholders agree on what that percentage is, and then we can build on what Mike has just said in terms of the cost savings now kind of, reappropriated to primary care as it should. But we have to agree that, first of all, 5 or 6%, whatever it is now, is low, and what should it be? And we can keep looking at that.
Okay. Scott, Dr. Berkowitz. Thank you, Dr. Okiki. Any comment?
Just I guess kind of a question. So when you're talking about budget neutrality, you're talking strictly about the primary care allocation of spend, and this may have been getting to the earlier question as well, but is really the metric that we would want to think about sort of total spend, and that if primary care gets a little bit of additional support so that it helps to alleviate or reduce unnecessary utilization or total spend, is that more the goal? And so I don't know if we have to be as prescriptive on the primary care piece, or if we should be thinking about it from the total spend perspective.
So I would yield to Dr. Hack, Dr. Reedman. My sense was that they were actually thinking about the total program, but I don't have any confirmation of that. Perhaps somebody else here has a viewpoint on that. Maybe Will, are you there? Have us on mute.
Hi, David. How are you?
Hello. Thank you. Any reaction, comment here to?
Yeah, I mean, I think patient care first, the federal model, sort of is envisioning a substantial increase in primary care payments, but they're linking it to, success at reducing hospital utilization and the total cost of care. I think that the model that's envisioned here is up to a 35% increase based on, success at reducing the total cost of care. I think that's pretty substantial. And so I think this model is sort of, satisfying Dr. Reedman's concern where, you could see a substantial increase in primary care payments, but it has to be conditional on sort of success and outcomes.
Good point. Any other comments from council members? Dr.
Did you call me? I didn't hear.
Yes, please proceed.
I agree with that, with one just not modification, but the base should be increased to capture the substantial increases that are going to happen on January 1st. That should go into the base amount, not at risk. And that's going to be about 10%, 8 to 10% with a blend of internal medicine, family practice, et cetera. The rest of it could be at risk for achieving certain objectives, but there should be an increase in the base, at least to include that redistribution that's going to happen at the federal level in the fee schedule.
Understood. Thank you. Bob, are you at a point where you can weigh in?
Which Bob? Me?
Yes, sir.
Well, it's all. Sorry, here. Let me. I'll even make myself visible. We're when we think about the cost here, we've got the total cost of care commitment to the feds. We're the only state where there's a real risk there. And, so far we've been spending, and by the way, my preference would be to say, yes, invest heavily in primary care because it's the right thing to do. The question is, can we make it pay because of the fact that we do have this risk in the greater model, which the hospitals will pay the price for if we don't succeed. So, that's really, that's the question about the trade-off. I mean, payments, care management fees in this current year are in the $120 million range. And that it gets added to total cost of care. We are currently saving money against the targets, but there's a lot of claims against that savings. And so, right now in 2020, we certainly have not gotten a deal from CMS on how we'll treat 2020 impact of COVID. So, just I guess the bottom line is, let's not be profligate without consideration of where the ROI will come from. It's certainly not trying to be cheap on the primary care side.
Yeah, I think that in my opinion, is that the program overall obviously needs to be neutral, revenue neutral or budget neutral, and maybe even savings, but there's got to be a shift in where the money goes. And if you look at the payment to specialists, it's significantly and dramatically higher than primary care. And so there is, in my mind, as a primary care physician, there are a lot of dollars out there that could be shifted from specialist care to primary care. In particular, specialists had more of a skin in the game. And I'm not sure that really falls into this program and how our recommendations from this committee fall into that. But I've had that conversation, and we've had the conversation before about, who's responsible for the total cost of care. And the reality is that primary care physicians have some significant impact on that, but the specialists are getting significant dollars in reimbursement that I think could be shifted somewhat to primary care. And again, I don't think that falls into this committee, but I think there are dollars out there that could be spent in a different way. And increasing the primary care part of it to some degree would be part of it, especially if there's increased responsibility.
Well, if I may just reply and try to be supportive to that, if I often try to pretend I'm the payer, in this, and say, and I'm at risk, it's my dime that everybody else is spending. And, so when we look at total cost of care, you're right. I mean, the percentage of total spend goes to specialists is bigger than the percentage that goes to primary care, especially in Medicare. But then we also have skilled nursing facility care. We have, and home health, all the post-acute stuff. So we need to look across the board at where we might expect the investment in primary care to pay off. That's a broader exercise than what might be getting prepared for here with regard to just within the primary care envelope. But I think we need to link up between the two domains and do an overall analysis and get the HSCRC involved in the mix.
Okay, so thank you.
Can I make a quick comment?
Gene, please.
Yeah, so I actually agree with what Bob said about looking at everything. And one of the things that frustrates me to no end is the drug companies never get talked about. We're sitting here figuring out how to, take away from this or take away from that, but we never talk about drugs, as someone who, maybe some money needs to come from the drug sector and come into hospitals and physicians, and instead of us sitting around and looking at people who are actually providing care and providing value, maybe we can look at some of the entities that aren't and are just spending a lot of money on advertising and all, but we never seem to do that. But I guess my question is more about this specific issue. When they say, or when we're talking about budget neutrality relative to the fee for service, are we just talking about budget neutrality with regards to fee-for-service for primary care doctors, or are we talking about fee-for-service for everything and we want budget neutrality for that? I'm a little confused because we've kind of said it both ways. I would argue if we're talking about just the dollars that are kind of allocated to primary care, then that clearly is a problem, which I think other physicians have said, because, not only we're asking physicians to do a lot more than they normally would if they were just providing service type care. This is a lot more work. So we've got to figure out how we pay for that additional work we're asking all these doctors to do as part of this grand experiment. So I just would like some clarification as to what we're talking about there.
Dr. Haff, can you talk a little bit about the notion of budget neutrality?
You're muted, Howard.
Sorry, I didn't mean to mute myself. I didn't realize I did. So I think that the three things that are highlighted here are just the three sort of tiers that we would consider as we go to, after looking at the modeling and picking some cut points for investments. Do we intend to just make this another about the same 5% or whatever you want to call it that primary care gets now through fee-for-service, independent of MDPCP? Do we want to have as our cut point that we're comfortable at the level of investment that's being made in MDPCP, all in being equal? Or is there a different level, either above or below that, of primary care spending that we should be targeting? Knowing that, so we'll have the ability to make some adjustments in the both in the payment models and also the amount that's in each tier. So where do we want to, and on the broad basis, do we want to land someplace back where we were with fee-for-service, somewhere where we are with Maryland primary care, as Bob pointed out, is the non-visit-based payments that are about $120 million a year for the 474 practices that are in the program now, or do we want to look at a different number above or below that? I think that's what this question is asking.
Dr. Berenson.
So before you do that, Howard, I just about the muting. First of all, I don't know if anybody else saw it, and maybe it's a computer glitch, but I did see a little tab come up on my screen a minute ago. It said Bob Atlas muted Howard Haff. So I just throw that out there.
Sorry, that was not intentional, but it was fun.
Is that the gag order, Bob?
I didn't think we can't even chat with each other, but apparently we can mute each other. So
I thought we did it on purpose.
Perfect.
So do I have the floor now?
Yes, you do. Sorry.
I just wanted to make 2 points. One is that, again, to beat a dead horse, the increased payment to office visits for the 2021 fee schedule will be paid for by specialists. There will be a reduction in the conversion factor of 8 to 9%. The AMA and a lot of the specialty groups are trying to take a run at Congress to repeal budget neutrality for this year. That's not going to be successful. And so when you're looking at how to pay for any increases to primary care, understand that the specialists are already pissed off that they're losing about 9% on the Medicare fee schedule. That's not coming from hospitals. It's coming right from the specialists. What was my second point? Hold on just 1 second. I forgot it. So they're two of them very important.
Bob, so I'm clear on what you just said. So you're saying that there's already a reduction in specialist fees of 9%, and that's supposed to go to primary care?
Yeah, that's what pays for the increase. Office visits go to everybody who does office visits. So there will be some internal medicine specialties. Rheumatology gets a 16% bump because they do office visits. All of those increases, as well as a fee for complex care, extended care for complex patients, which is also going to be a new wrinkle, will go mostly to cognitive specialties, and it will be paid for by a reduction in every other service in the fee schedule. So procedures, imaging, interpretations, you name it, will all come down to pay for it. And And because there is a budget neutrality provision within the Medicare physician fee schedule, and that's how it's worked for 28 years. It's just such a big number this year that the AMA is arguing that with COVID and everything else, they can't, the other docs can't handle the cut. But that's, I don't think they're going to be successful with the Congress, and I think that redistribution will occur, and so the specialists will already be unhappy.
Okay, thank you. Will, did you have a comment to make? I can't tell if you were
Yes,
waiting.
thank you, David. So I guess I agree with the points that have been made previously about investing in primary care, and maybe there's a potentially higher level of the total cost of care that needs to be directed towards the primary care. However, I think in the context of the Maryland model, we are, for better or for worse, in a situation of budget neutrality. And so if we think from this model that we are going to be able to increase the share that goes to primary care, I think it's going to have to be at the expense of someone else. And the way that we do that is by holding the practices accountable for the total cost of care and paying them the shared savings, or a share of the savings or entirety of the savings that they get from reducing the number of specialty visits. And I would sort of think that it's a pretty good deal, right? If you're a primary care doctor, you can get those huge salaries that the specialists get just by making sure nobody goes to that specialist. And that I think being on the upper end of the stream is a good position to be, right? So we've, Dr. Riedman, I think last meeting or 2 meetings ago, I think encouraged us to start talking to the specialist about more risk-based arrangements, and we've been doing that. But those conversations tend to be more difficult because there's sort of less get that those specialty groups have. So, for example, when we talk to SNFs, or post-acute care providers, they're very excited about moving into value-based payment arrangements. And then we say, well, how do we reduce the total cost of care? And we say, well, reduce your length of stay. And they say, well, that's how we get paid. We can't actually reduce the total cost of care. And, we sort of, say that we're sorry, right? But the true answer is that they're on the wrong side of the spear. And I think the same is true, with the specialists, or at least some of the specialists, right? Whereas you move towards value-based payment arrangements, they can't really get total cost of care savings because they're on the wrong end of that spear. Well, I think the primary care docs are on the right side of the spear. And so while I think increasing the level of investment in primary care is definitely good, I think we have to recognize that we're in a situation of budget neutrality under this model, and that the way that you succeed is by sort of taking from somebody else, although I hope there are no specialists listening to this call, so Dean, maybe plug your ears or something like that. And so I think, that sort of when we think about increasing the level of payment that goes to primary care doctors, I think we have to be very cautious about that, because if we increase it without succeeding at reducing the total cost of care, we condemn everyone to failure.
So, thank you, Will. Dr. Berenson, are you wanting to weigh in?
Yeah, I remembered my other point. Just another data point, if anybody's interested. There's been 4 or 5 papers done from 10 to 15 years ago, which documented that on average, primary care docs do about 25% of their clinical time spent in a day is not paid for. There's no code for it. It's phone calls, it's prescription renewals, it's filling out referrals, it's talking to other physicians. Some amount of that happens for other specialties as well, but probably not as much. Fortunately, we don't have the data from other specialties. But if one were converting from fee-for-service, let's say, to pure capitation, one would probably use that number, that 25%, to say, here's we're paying for your full-time activity, and you got to factor in that 25%. So I am sympathetic to not just doing it without performance, but it is clear that we are underpaying for the new responsibilities that we're expecting of primary care docs, as Dr. Riedman says. Population health and social determinants of health and everything else that we're now expecting primary care to do. A lot of that doesn't have a code, it's not paid for, and we're trying to now make primary care practices whole for what they're doing. So that's just a piece of data to have.
So, Dr. Friedman, do we recognize here that the goal is aiming for budget neutrality, but yet how we get there is still an open item? Can we note it that way, or did you have a different approach?
No, I think that what I'm hearing, and maybe I'm hearing what I want to hear, but and that is that I think we all agree that an increase in payment to primary care for the extra responsibility is appropriate. Where that money comes from, and the fact that we all agree that the total cost of care can't go up because of that a redistribution of where the money's going and more of it to primary care is what we're suggesting. I think that everybody's in agreement with that. I haven't heard anybody say that that's not what we should be doing.
So just to frame up Alana's response, so it's budget neutrality overall, but increased payments to primary care providers.
Yeah, kind of everybody else goes down and we go up, I think is what I'm saying.
Okay. And this is just us entering notes for the moment. Does anyone else have any thoughts? Is this an appropriate response, or?
I just make one comment, and Bob will probably appreciate that. But I feel like the hospitals in particular and the primary care physicians are really are the ones that are working hard, trying to figure this out, doing the extra work, having the responsibility, extra work. Their skin is in the game. But and it was also mentioned about and I've mentioned this before, but the people who aren't necessarily have skin in the game are the specialists to some degree, certainly the pharmaceutical companies, and even in some degree, and I know it's politically not appropriate, but even the patients. We have patients. I had a patient the other day who had poison ivy, and they said they went to the walk-in center because they were out of work and they were closed at 10, so they went to the emergency room for the poison ivy. I think there's got to be some responsibility on everybody's to cut the cost of care. And right now, I feel like a lot of it is on the hospitals and the primary care physicians. And I think that if we're really going to cut cost of care, total cost of care, everyone, including the pharmacies and including the patients, need to be involved in this. And again, I don't know if that's in the perusal of this committee, how much impact we have, but those are the things that I think are really going to cut the cost of care, the total cost of care. So I agree with that.
Thank you. Bob?
Yeah, amen to that. I'll just say, in a way, we can't just go for budget neutrality. The whole point is total cost of care savings. Okay, so we have to pay back what we take for primary care and some. And to the point Gene made about drug companies, the thing is, Medicare Part D isn't part of this. At all. There are drug costs, obviously, administered under Part B and Part A. We certainly can look at that. I'm not opposed to that at all. But yeah, I'm going to be a broken record here. We've got to marry up the overarching objectives of this program with the overarching objectives of the total cost of care model. Otherwise, we're on hand.
So, Bob, if we said here at the end, if we said in parentheses, total cost of care savings, as to sort of note that, does that capture the thought you were sort of making here?
Yeah, I think so. As long as everybody understands, total cost of care, what total cost of care really means, and we should be good. But we're we're on page 1 of a 12-page document. There's a lot more to talk about. So this, hopefully these themes will carry through and we won't have to repeat this.
Understood. Dr. Haft, you were going to say something, I believe?
No, I was going to say just what Bob said. I think it's time that let's see if we can get to some more specific items and see what things we can cross off the list.
Yep, I agree. And I think that Bob's comment that I think a lot of these themes will kind of flow through, or the discussions will, just when we're getting started. There's a lot of redundancy in our discussion, I think, as we go along. So let's, I'll have Alana scroll up to item number 2. And
while you're scrolling, I do just want to defend my drug comment. I obviously understand that D is not included. It should be included. It is bullshit that, like when the ACO program was set up, we excluded drug costs. We continue to not talk about drug costs, and I think, frankly, we should stick in here and we should get some kind of incentive or benefit for reducing drug costs. We take this industry and put it to the side, and then they stick us all in a room and say, we got to cut the pie up smaller so we don't hurt them. And I find it incredibly irritating. And I will also say, in defense of my specialists, because Medcare represents all doctors, that I do know there are some specialists who do want to make a difference and move to these. The real difference is a lot of the specialists are really just economically incentivized in the total old system, and we haven't really created good models for them to do it. And I do think there are some who are trying to figure it out, and that's a longer and more complicated conversation than we should have now.
Yeah, agreed. Thank you, Gene.
So if there's no more comments on that, I'm not gonna in the interest of time, and I'll read through the primary care first part of this. I think we've all been through it before and understood it. The alignment was agreeing with the national benchmark, and so I'm just going to go ahead and skip to let Howard start our conversation on the unresolved items, rather than reading through the different payments and the performance-based adjustments. So I'll turn it back over to you, Howard.
Thank you, Michael. I think this was actually what we talked about in the last bullet, was number one, use state-based performance adjustments consistent with the current model and aligned with population health goals. So that this is to see if we can agree that the state sets its own, as we're getting input from the advisory council now in terms of what our quality goals are. We should be able to not adhere to the primary care first quality goals in their matrix, but continue to set our own quality goals aligned with the SIHIS, the state population health improvement goals, and then also to simplify it to the extent possible and annualize the adjustments rather than on a quarterly basis. I think those were the points that we presented to CMMI, and I think we're just looking for some more details about how we would do that.
Is so any reaction from council members to Howard's point, Dr. Haff?
I was just wondering about the full PBA from year one in track 3. Is that to be explored, or to have a thumbs up, thumbs down on that? Only asking because when I did read the document, it said full PBA for the first year, and then that would change in year 2. If you scroll down a little bit, Alana, I think you summarized it there during second performance year. Yeah. So question is, should we flip this, and being aware that utilization, as a final outcome has other, confounding factors that is also included in the quality matrix here and the quality gateway threshold. Is that something that we should do in the first year instead of just having the first year be only utilization? So I don't know if that is what meant by that bullet point, but that would be my reaction to that.
Dr. Haff, any sense that?
No, I think that would be a decision that the would be guided by what the council says. If there was a ramp up period for between the first year of performance in track 3 compared to the second or subsequent years, I think that's an acceptable model also. I think that the question then would be, if in the first year your adjustment on the performance is based only on utilization, it puts a lot just on utilization. So I think it's just a discussion that we appreciate the council's input on. This is it's a model feature that can go a variety of different ways.
Yeah, so I think there could be a policy end to this or a clinical end, but maybe it's interesting to try to get both perspectives. So, Bob, any comments on the policy approach?
You got 2 Bobs here. I know that's a rarity, but I assume it's me again.
Us doctors get to be called doctor, not.
Yeah. Okay. Well, he's the doctor. I'm the not doctor. Anyway, well, I I don't know that I fully appreciate this one, but I see this thing that says at the top of column C or 3, practices are motivated to reduce acute hospital utilization. Okay, so, that's the thing, since that's not going to generate dollar for dollar savings, given the GBRs, I think this is where we might want to deviate from the national approach and, it is sort of, replay on the conversation we just had about specialty care and drug costs and skilled nursing and so forth. Fine, let's see where we can actually get total cost of care savings. I mean, there is in the long run, there are savings from reducing hospital utilization. The GBRs are not fixed in perpetuity, but it's not an instant savings to the Medicare program when you reduce utilization. Of course, there are benefits, and I'm not going to deny that in the least, and hospitals are prepared to see that decline and want to. But this is an opportunity to be creative and suit and fit this to the bigger model.
Good point. Thank you. Dr. Berenson, your reaction?
Yeah, no, I agree. And again, I've suggested that rather than focus on, I've actually seen some recent data. I haven't studied it in any detail that says that incentives for reducing ambulatory care sensitive hospitalization hasn't saved any money. Hasn't worked very well. So if we're going to do something that doesn't work very well, I'd rather reduce unnecessary referrals to specialists. That's one way the specialists could be part of the game, is to actually focus a little more on the primary care specialist relationship. The American College of Physicians has had some recommendations in that area about how to improve referral mechanisms, how to decrease referrals, unnecessary referrals. And again, we're not ready to do anything like this next year, but I think that might be a fruitful area to begin to develop some recommendations and ultimately with some performance measurements. The increase in referral rates has been dramatic in the last 15 years and is continuing to go up. And I don't blame primary care physicians to some extent because they have so much to do that it's easy to just refer. But under a capitated model, at least a partly capitated model, the easiest thing to do is just refer to a specialist, and that will drive up costs significantly for ambulatory care. And I just think we need to get a hold of that. Again, not for this year, but as an intent going forward.
Interesting. Patrick, any thoughts here? Okay, we may have.
Let me, if I may just toss in one more thing, and that is, performance doesn't necessarily have to be about savings. It can be about, health improvement, quality of care, et cetera. And so, and the SIHIS, that acronym, Statewide Integrated Health Improvement Strategy, it's got 3 elements to it. It's got population health, it's got quality, and oh damn, I'm forgetting the other all of a sudden. But let's look for ways to reward physicians for contributing to those overall goals.
Very good point. Anyone else want to make a comment here? So oh, go ahead.
Yeah, if I can, I think that everyone's absolutely right. I think what I think will be pretty straightforward is after we decide that this should be state-based decision making about what the incentives and the disincentives should be, that the bundle that we choose will fit into the state model. So it will naturally include something related to quality, aligned with the state improvement goals, something having to do with consumer satisfaction, whether it's the current caps or some other. Something having to do with utilization, since that's unavoidable in some ways, in order to align with the primary care first, whether it's heavily weighted or slightly weighted. Something seems to be a significant portion of the incentives here to go toward appropriate use of specialty referrals and ancillary referrals, those kinds of things, and then of necessity something related to the total cost of care, because we're all in this together. I think it's just I think we've all talked about that and agreed that those are the things that we want to include, and it's just a matter of weighting them and deciding how often to meter that out, and perhaps a little benchmarking work. But I think that to me sounds like we've come to some great conclusions here and what we want to do. It's just a matter of now codifying and refining it a bit. Does that sound right to others?
I think that sounds good. I think what we'll do, we have Kevin Hayes wants to make a comment. Before Kevin weighs in, I think, Alana, it's essentially almost a cut and paste from, at least from that first bullet point in column 4 over to the next. I think Dr. Haft is saying there's more to be done here in the detail. We have Dr. Reedman about 5 minutes. Would you like to conclude with Dr. Hayes's Kevin Hayes's comments?
Yeah, let's do that, and then I'll just make one comment.
This will be brief, which is just, I'm wondering, we're wrestling here with this question of total cost of care and relationship between primary care and total cost of care and all. What kind of feedback will the practices receive on this last bullet point having to do with total cost of care performance adjustment? And the reason I'm fixating on that is because that may be, if we can make that actionable, if we can make that informative enough, it will not only show the practices, but it will show everyone what the influences are on total cost of care that might sort of lead toward further improvements in how we try to provide incentives to the primary care practices. That's all.
Very good point. Thank you.
I think Kevin's point's very well taken. That the feedback to know where the improvements can be made is going to be very critical. I'm just going to make, since we only got a couple minutes left, I'm going to make just an editorial comment about what not ND Bob but MD Bob said about the referrals to specialists, and that is that we're in a really tough position in primary care because we're in a transition phase. We're still in a lot of ways being paid fee for service, but also, and that's a volume-based practice versus we're being asked to kind of shift over to population health, which is really more of a supposedly quality care and more income for longer visits, et cetera. But we're in a transition phase right now, so we're getting paid one way, but being asked to do things a different way. And that transition period is really tough. And I think that the delay that we're having in 2023 is going to be really important for primary care physicians. But I think Bob's point is really good that, when you're an hour behind and someone's got X problem, it's really pretty easy in a fee-for-service world or volume-based world to say, let me send them to specialists. So I think as we shift to more of the population and the payments go up and the reimbursement becomes reasonable for spending the next time, and I'm hoping that will improve. We're in a tough position in primary care for that reason right now. So having said that, we've got 2 minutes left. I would like to just reemphasize what we talked about before, that I know everyone's really busy and hopefully things won't flare back up with COVID this fall, but I'd like to keep on our books for Tuesdays, having these meetings and making them as efficient and hopefully moving through things quickly, especially as we get into the latter parts of these pages. A lot of the other stuff is less controversial and less comments on it. And we'll shoot for Tuesday meetings, and we may skip 1 or 2 in there, but I think we keep the momentum going while we report back to CMMI, and then we just wait for their responses, but we keep moving despite that. So I'll throw it back to David and Melanie for the comment.
Yeah, thank you. And Jean, thank you for your text. Melanie, can you make an operational statement? And then I would open it up to our executive director to Ben's passing. Okay. Melanie, operationally?
Yes, thank you, David. So this table is going to serve as the record of what's being discussed. So the tables will be posted along with a high-level meeting summary, as well as the record of these meetings to the MHCC website. And those will go around with a follow-up email to everyone to link to the MHCC website. And, as Dr. Reedman mentioned, we'll be having the meeting. So look for those invitations coming from an MHCC staff member.
Okay.
Everybody's waving at the baby.
I think we've been pleasantly distracted, but with that, Dr. Reedman, if you're fine with it, we can conclude and wish everyone a great evening. And thank you for your time and great conversation this afternoon. Take care, everyone. Be in touch.
Good night.
Bye.
Thanks, everybody.